We have worked with some colleagues, gynecologists, dentists, to do this work. And it's entitled Effect of the Menstrual Cycle on the Periodontium and Pro-Inflammatory Cytokines, Interleukin-1, 6, and Tumor Necrosis Factor Alpha on the Periodontium of young women residing in Yaounde. We will adopt the following plan. Okay. To introduce, we'll say that periodontopathy are a group of inflammatory diseases that affect the dental supporting tissue, and generally due to poor brushing and flossing habits. It is initiated predominantly by the accumulation of anaerobic gram-negative bacteria with signs and symptoms being red and swollen or tender and bleeding gums, bad tooth, and loss of sensitivity of the teeth and receiving gum. So, according to the World Health Organization, the prevalence of periodontal disease in the world is about 20 to 50%, while in women it's 23%. The Center for Disease Control in the United States reported a prevalence of periodontal disease of 47.2% in the US. And in Africa, some study noted a prevalence of 60%, while in our country, some study reported a prevalence of 98%. In the pathogenesis of the periodontal disease, the initial presentation of the disease localized in the gingival tissue known as gingivitis, which is the inflammation of the gingiva and is mild form of the tissue of the disease. However, the disease progresses, and if allowed to progress, especially due to improper hygiene, can lead to uncontrolled inflammation, resulting in periodontal attachment loss, bone destruction, leading to loosening and subsequent loss of teeth, which is defined as periodontitis. This seriously affects patient quality of life, causes a tremendous social and economic burden. We can also observe the systematic disease affecting the periodontium, periodontal abscesses, or endodontics periodontal lesion, mucogingival deformities. So, links have been shown between systematic factor and disease prevalence, progression, and severity. Some risk factors of periodontal disease include diabetes, tobacco, smoking, drug, stress, obesity, pregnancy, stress, age, and others. Its treatment can be surgical or non-surgical. 3 pro-inflammatory cytokines, interleukin-1 beta, 6, tumor necrosis factor alpha, have been shown to have a central role in periodontal tissue destruction. The initiation and progression of periodontal disease are related to multiple etiologic and risk factors, the most important of which are the local microbiota and host immune response. Cytokines are the key modulator of both homeostasis and inflammatory process that act in the first waves of response against pathogens and stimuli at barrier sites and connect tissue. So, however, many recent studies have found that single nucleotide polymorphism in cytokine and associated receptor encoding genes are related to the risk and severity of periodontitis, which indicate that the disorder regulation of cytokines initiate or accelerate the disease. Cytokine 1, 6, and TNF-α are said to favor gingival inflammation, periodontal tissue destruction, and they also play a major role in the initiation of phases of periodontal disease and bone destruction. There is a change in pro-inflammatory cytokines all through the menstrual cycle, especially the second phase, which could be related to hormonal fluctuation during the cycle. And these cytokines cause systemic effects such as increased body temperature, neutrophil metabolization, and increased lymphocyte activation. The reproductive system of female shows regular cyclic change that may be regarded as periodic preparation for fertilization and pregnancy, known as the menstrual cycle, which can affect the periodontal tissue and its function. The reproductive system of a female, unlike men, shows regular cyclic change and may be regarded as periodic preparation for pregnancy and fertilization. The most conspicuous feature is the periodic vaginal bleeding that occurs with the shedding of the uterine walls, called menstruation. And the menstruation cycle is controlled by hormones secreted in the hypothalamus, pituitary, and ovaries, principally estrogen and progesterone. And they were responsible for continuous ovulation until menopause. And the phase of the menstrual cycle vary with respect to person's cycle. There is a follicular phases, ovulation phases, and luteal phases. In the periodontium, epidemiological, biochemical, and immunological evidence have implicated sex steroid hormone in the etiology of inflammatory gingival disease due to its variation through the menstrual cycle. A study done shows that the menstrual cycle affects locally released pro-inflammatory cytokines. Also, tumor necrosis factor and other cytokines may be responsible of the endothelial cells retraction and increased vascular permeability. The manifestation of pro-inflammatory cytokine and their effect on the periodontium during the menstrual cycle is not totally known, and this is the reason of this study, with the purpose was to describe the effect of menstrual cycle on the periodontium and pro-inflammatory cytokines, interleukin-1, 6, TNF-α in young women. And more specifically, we aim to evaluating periodontal modification with the menstrual cycle, analyze pro-inflammatory cytokine during the menstrual cycle, and describe the relationship between periodontal pro-inflammatory cytokine and periodontal parameters during the menstrual cycle. So, to achieve this objective, we carry out a longitudinal prospective study in the implantology and periodontology laboratory of our faculty, and the analysis were done in our laboratory at the Yaounde University Teaching Hospital. The study population was composed of young women with a regular menstrual cycle residing in Yaounde, and exhaustive consecutive sampling technique was used. We therefore include consenting participant aged between 18 to 35 years, with regular menstrual cycle, non-smoking, and having no systemic disease, with a healthy periodontium, that is the absence of tartar and any form of inflammation. We excluded participants using oral contraceptives, antibiotic therapy, or use of non-steroidal anti-inflammatory drugs, with irregular menstrual cycle, and participants will withdraw themselves from the study. We proceed as follows. First of all, we obtain ethical clearance from all the board from our university and from our country. The research authorization was then obtained from the hospital, and the confidentiality was respected. We then approach eligible participants to whom we present our study. To those that gave their consent, we interviewed to verify the inclusion-exclusion criteria. For each participant enrolled, we collected relevant sociodemographic, clinical, and laboratory data. We started with a dental phases, which consisted of an oral consultation, a full mouth scaling, and dental hygiene instruction for each participant 3 weeks before the study. We then took clinical periodontal parameters and collected gingival clavicular fluids, and this was followed by a biological phase subdivided into the pre-analytic, analytic, and post-analytic phases. The oral consultation consisted of Nothing plaque index according to silness and lowe, gingival index according to lowe and silness, presence or not of bleeding on periodontal probing, as well as periodontal pocket vet and clinical attachment level, which were done with the use of a NABA periodontal probe. These parameters were taken at 3 phases of the menstrual cycle: follicular phases from day 2 to 5, ovulation phases from day 13 to day 15, and the luteal phases to day 22 to day 24. We proceed Then with the gingival crevicular fluid collection, which is a physiological fluid as well as inflammatory exudate originating from the gingival plexus of blood vessels in the gingival corium subjacent to the epithelium lining of the dentinogingival spaces. Collection of the gingival crevicular fluid, which was done generally in the morning using sterile paper point insert in the gingival sulcus after being compressed and gentle hair stream and isolated from cotton rolls. The paper points were maintained for 60 seconds in the sulcus, after which they were transferred into a label-dried tubes containing 1 milliliter of distilled water and taken to the biochemistry lab for storage and analysis. At the biochemistry lab, the sample collected were immediately centrifuged, spinning for 10 minutes, and the supernatant which settled on top were removed with a pipette and transferred into cryotubes, which were stored at -20 degrees in the refrigerator. The supernatant collected were later analyzed to determine the quantity of cytokine using the sandwich method ELISA. And the principle of the ELISA enzyme link immunosorbent assay test, it requires 2 antibodies specific for different epitopes. One of the antibodies is coated on the surface of multiple well plates and used as a capture antibody to facilitate the immobilization of the antigen. And the other antibody is conjugated and facilitate the detection of the antigen. And after adding a secondary antibody to the enzyme, the mixture in the presence of the substrate gives a blue coloration. And finally, after adding sulfuric acid, we obtain a yellow coloration, which marks the end of the procedure. The absorbance were read at 450 nanometers. From the absorbance value observed, we extrapolated and plotted on the standard curve to obtain our concentration in picogram per milliliters. For statistical analysis, we use CS Probe 7.7 and Microsoft 2016. Our result. we obtained 50 participants, but 25 were excluded on account of different reasons, such as irregular cycle, use of oral contraceptives. So we have included 25 patients. The mean age was 22 years, and 80% of them were single. 48 of participants had visited a dentist in the past. Among them, 24 had gingivitis. 52% brushes once per day and use medium brush. 48 of the participants complained of oral discomfort during the menstrual cycle, which greatest percentage noted during the luteal phase, 22%, followed by 12% on ovulatory phase, and the lowest 4% during the follicular phase. Most frequent complaint was bleeding during brushing, with, which was 44%. 24% of participants consumed alcohol, of which 20 took at least a glass per week. So, during this study, periodontal parameters such as plaque index, gingival index, periodontal pocket depth, and clinical attachment level were considered and noted in the 3 phases of the menstrual cycle. In the follicular phases, all periodontal parameters did not show significant change, and this could be explained by the fact that all participants received a full mouth scaling before the study. But during the ovulation phase, 40% of participants experienced slight change on the periodontium, while 64% manifest during luteal phase. We observe a slight in the gingival index from the follicular phase to the ovulation phase, which remained constant in the luteal phase. And there was a slight increase in pocket depth and clinical attachment loss in the luteal phase, which was not statistically significant. Only gingival index was statistically significant with our study, which is comparable with similar studies. and to different studies. Concerning the biological phases, a significant increase was observed in interleukin beta level in the gingival crevicular fluid from the follicular phase to the ovulation phase and equally the luteal phase. We can see it growing. The change in inflammatory cytokine observed in this study are similar to those findings of some authors. Interleukin-6 found in gingival crevicular fluid showed a substantial increase, which was remarkably high in the luteal phase than the other phase. Here. And this increase was observed throughout the cycle, and this is similar to the finding of some authors. The change noted in the interleukin-6 could be explained by the change in the production and secretion of progesterone and estrogen observed during the menstrual cycle noted by Milley and collaborators. Also, according to others authors, progesterone enlarged small vessels and increased vascular permeability, which affect the polymorphism of leukocyte activity and increase inflammatory cytokine levels. On the other hand, tumor necrosis factor alpha level in our study varied throughout the cycle, with the highest value observed during the ovulation. This finding is inconsistent with the result of Beza and collaborator in the United States, in which study there was a remarkable difference of TNF-α found in gingival crevicular fluid during different phases and the highest level observed during the luteal phase. But again, this study does not corroborate with that of Groban and collaborators who had a significant increase of TNF-α all through the different phases of the cycle. We also sought out a relationship between periodontal pro-inflammatory cytokine and periodontal parameters throughout the 3 phases of the menstrual cycle. Interleukin-1 beta were statistically significant with the value of gingival index during the ovulatory phase, while the plaque index observed in ovulation and luteal phases were statistically significant with that of interleukin-1 and tumor necrosis factor. The slight periodontal change observed throughout these 3 phases can be explained by an increase in cytokines throughout the menstrual cycle, though the increase wasn't very visible clinically. In this research, the level of tumor necrosis factor, interleukin-1 beta, and the gingival crevicular fluid increase from the follicular phases to the luteal phases of the menstrual cycle, and tumor necrosis factor was statistically significant. And this may be due to the change in estrogen and progesterone level. The different mechanism of action of progesterone control the stimulation, production, and role of TNF-α interleukin-1 beta in periodontal inflammation. And the difference in the result obtained in our environment could be due to the race and the lifestyle, as this factor influence sex hormone and fluctuation during the menstrual cycle, and the periodontal status, the rate of secretion of inflammatory cytokine in the gingival crevicular fluid. So, taking into consideration this change during a patient consultation will be very important for diagnosis and treatment. A patient response to surgical and non-surgical treatment during different phases of the menstrual cycle is important to understand. For example, some authors reported that the menstrual cycle could be a determining risk factor in the frequency of alveolar osteitis after 3rd molar surgery. Therefore, the menstrual cycle may be a risk factor for alveolar osteitis and periodontal disease progression due to the hormone fluctuation. Hence, practitioners are called upon to make note of patient menstrual phases before any treatment, and it could be determined for health. So, in conclusion, we can conclude that Only gingival index was statistically significant, accompanied by a slight inflammation on gingival tissue during the cycle. There was a considerable increase in pro-inflammatory cytokine throughout the menstrual cycle. The increase of pro-inflammatory cytokine during the menstrual cycle had slight effect on the gingival tissue with little gingival inflammation. So in our context, we sought to recommend to young girls to keep a good dental hygiene, be able to know their cycle and count, consult a dental practitioner after every 1 year or in case of any oral discomfort,